Good afternoon. And before I start to talk about HPA axis, I would like to thank to Diamanti Kandarakis for kind invitation to this, may I say, spiritual meeting. It's wonderful to be here and to talk about aging. And as we are getting older, I mean that we become more and more aware of aging and about physiology of aging. And that's very important. Sometimes it's very hard to make a distinction between physiology and what we call pathophysiology. So I'll start to talk with the definition of aging. And I'm going to talk about actually genetic definition of aging. So decline or loss of adaptation abilities induced by decrease of Hamilton forces of natural selection is an official definition of genetic aging. So if we are talking about these Hamilton forces, these forces actually significantly affect mortality of a specific generation. And recently, actually about 40 years ago, I say recently because there are many trials before to make this definition, actually appeared that Hamilton forces are related to Malthusian index of growth population, and it is corrected actually for what we call survivorship. It is also related to fecundity, and fecundity is actually accomplished fertility of a specific generation. And that's very important. So you can see actually here that force of natural selection are the highest actually at the beginning of reproductive period, and these forces are gradually decreased with a late life and actually approach to the zero with last stage of reproduction. And that's very important. It's very important to understand for all actually nations in Europe. So from the genetic point of view also, it is interesting to define what is the senescence. What is the cell senescence? So actually, when you lose the ability, when the cell loses the ability to divide and still preserve mTOR activity, we defined it as a senescence. So adding in some cell lines rapalogs could actually revert senescent cell to so-called normal cell, to revert actually the ability to divide. So there are some differences between rapalogs, which acts mainly on mTORC1, and direct inhibitors which can block mTORC1 as well as mTORC2. But generally, most of these studies are conducted on the cell lines. So it is not very much applicable to human pathology or humans generally. And I couldn't simply to avoid just to mention some things. Actually, with aging, and especially in very old people, centenarians, some polymorphisms, or better say genetic variants, gene variants, appears more frequently than other. So we mentioned just a few moments ago FOXO. So some polymorphisms appears to be more frequent among centenarians, as well as some variants for the gene encoding adiponectin as well, TSH receptor, and as well IGF-1 receptor. And this is also, I think, important, suggesting that we may have some genetic background for the aging. This is also important. We live in the 21st century. We work a lot. That's what I think now. And it is important to notice that telomere length is reduced with hard working. And the life expectancy is also reduced among people so-called hard workers. So we have to think about that. So you have to balance what are you doing, you know, and how do you spend, may I say, your life and your free time. Now, to be able to understand what is going on with HPA axis with aging, we have to know some physiology about that. And as I said, and I want to say that everything begins with brain. So cortisol levels and its increases during the stress load are actually not important only for the brain function, but these are important for the brain plasticity and for the adaptive abilities of the brain. So what we know as endocrinologists is usually that the negative feedback of HPA axis is regulated by hypothalamus and by hippocampus. And at the very moment, I would just like to remind you that actually glucocorticoids are involved, and HPA axis through glucocorticoids are involved in energy homeostasis as well as in cognitive function of the brain. I mean, in cognitive functions. So mineralocorticoid receptor and glucocorticoid receptors, which mediate the effect of the glucocorticoids, are actually located within amygdala, within hippocampus, as well as within paraventricular nucleus of the hypothalamus, and gyrus cingulum, as well as in prefrontal cortex. So this is very important. I've just mentioned that, for example, in amygdala, actually that amygdala are involved in processing of memories with emotions. So emotional memories are related to amygdala. And learning memory is, for example, related to a hippocampus. And that's very important also. So all afferents coming from the upper parts or from the higher centers from the brain actually induce elevation of cyclic AMP within cells of paraventricular nucleus, especially in parvocellular part of paraventricular nucleus. So in some cell lines, it has been shown actually that substances that increase the level of cyclic AMP also increase the synthesis and the secretion of CRF as well as AVP. Even more, it has been shown that stimulation by cytokines are also mediated through cyclic AMP. So if you add to those cell lines in those media antibody to interleukin-6, you're going to see a reduction of the response in CRF response and AVP response. So this is a part of positive regulation of paraventricular nucleus. So you have already seen this slide, and I am going to use it again. So obviously, there are two great pathways which stimulates paraventricular nucleus. As I said, adrenergic afferents coming from the higher brain centers, stimulates CRF secretion and IVP secretion. On the other hand, central clock or suprachiasmatic nucleus can also induce secretion of CRF and AVP. So this suprachiasmatic nucleus is also associated, or may I say it's a creator of diurnal oscillations. So just to mention actually that in retina we have cells that sense actually light. And when the light fall down to those cells, the light induce actually by photons electric activity, and through retino-hypothalamic pathway, it actually excitate suprachiasmatic nucleus. And that's the way how diurnal rhythm is always connected with the daylight. So wherever you go, you are going to just connect your daily rhythms, you know, with the daylight. It is also of importance to know that even blind people possess these cells, and these cells are not involved in vision. So if they are preserved, even blind people also have correct diurnal rhythm. So after the CRH and AVP are delivered to the pituitary, ACTH is stimulated, and it stimulates the secretion of cortisol. However, central clock also stimulates through sympathetic tone, increasing sympathetic tone, also stimulates and facilitates the effects of ACTH. The net effect is secretion of cortisol, and cortisol acts through its receptor, glucocorticoid receptor. So the most important thing in biology is how to limit or how long the biological effect has to go on. And this is solved in this particular case, you know, by peripheral clock transcriptional factors. So every organ do have peripheral clock, which is synchronized with the central clock. And those transcriptional factors, actually, in this particular case, BMAL and clock, actually acetylate C-terminal part of glucocorticoid receptor, and it blocks transcriptional effects of glucocorticoids. So the process is stopped at this very moment, you know, and the peripheral clock is synchronized then to a central clock. So that's a part of the story. What is going on with mineralocorticoid receptor in peripheral and especially in brain, in peripheral tissue and especially within the brain? So mineralocorticoid receptor is a high affinity receptor for glucocorticoids, for cortisol. So even in low levels, during the low levels of cortisol, mineralocorticoid receptor is occupied, and you have biological effects actually continuously. Only during the very high, I mean during the rise of cortisol, there is a saturation also of glucocorticoid receptor. So may I say that the biological effects of glucocorticoids are actually pulsatile. This is very important to remember that both hormones and both receptors do have genomic effects and non-genomic effects. And those non-genomic effects of mineralocorticoid receptor and glucocorticoid receptor are mediated through tyrosine kinases, through intracellular tyrosine kinases. So the mineralocorticoid receptor actually is involved with increased, I mean, its activation induces the increase in electric activity of neurons, while also increasing by that way actually long-term potentiation. This is the main process during the memory, during forming the memory. So that's very important. And glucocorticoid receptor, through its non-genomic effects, also affects the function of neurons by increasing spine densities that makes synaptic connections more tight and more stable. So this is the way how glucocorticoids actually change the brain plasticity. And we have also genomic effects. So definitely both mineralocorticoid receptor and glucocorticoid receptor suppress long-term potentiation and enhance long-term depression. And this is also important for the balancing of memory. And this is also important how many informations you can store actually within your amygdala, or how many informations you can store within your hippocampus. At the periphery, we were interested a little bit in periphery, and we were interested especially in adrenal cortex. And what's the importance of this study is that we actually detected a specific form of glucocorticoid receptor, specific isoform and terminal isoform called glucocorticoid receptor D, which is the most prominent isoform within adrenal cortex. And if you analyze, the incidentalomas, you are going to see that only this isoform of glucocorticoid receptor is present among tumorous tissue. So that's very important because actually this isoform D is a nuclear resident, and it doesn't bind actually glucocorticoids. So it means that cortex can perform steroidogenesis, with maximal reduction of the effects of glucocorticoids. So it's a very special position in physiology of may I say, adrenal cortex among other glands. It is important also to know that epigenetic modifications also are important for the function of HPA axis. So definitely offspring of parents who were exposed to trauma do have more frequently methylized of glucocorticoid receptor. And this methylation, for example, in this region 1F, this is one of 5 promoters for glucocorticoid receptor, is associated with reduced glucocorticoid receptor function. So what does it mean, actually? It means that we are also programmed during the fetal life, that our HPA axis is programmed during the fetal life. So I know perhaps most of you know these studies, but actually the effects of leaking and grooming in mice nests of their offspring actually is associated with the amount of the glucocorticoid receptor expression at the hippocampal level. So definitely mice from nests with leaking and grooming and mothers who do leaking and grooming actually have offspring with higher number of glucocorticoid receptor at the hippocampal level, while those with low leaking and grooming actually have a lower number of glucocorticoid receptors at the within the hippocampus. And this is very important for the negative feedback in the whole life. So some actually, those with higher sensitivity of HPA axis are associated in the life, you know, with high frequency of, let's say, infections, while those with reduced negative feedback are associated with metabolic syndrome. Now, what happens with aging? So first of all, it has been shown that the number of glucocorticoid receptor as well as the number of mineralocorticoid receptor decrease with aging. It is also important that the level of hydroxysteroid dehydrogenase 1, which convert in mice dihydrocorticosterone to corticosterone, and in humans cortisone to cortisol, actually definitely is decreased. And it has been shown within hippocampus. And it has been shown that elderly mice with specific knockout for the hydroxysteroid dehydrogenase type 1 show spatial memory retention, actually decrease spatial memory retention, suggesting that the level of cortisol or corticosterone is necessary for the normal memory. Besides, as in stress, you are going to see in men and women also decrease of arborization, of dendritic arborization, and decrease the number of spines I mentioned before. So this is also associated with the aging. And it is of importance, of course, that some human studies also show that in elderly there is a correlation between the volume of hippocampus and the fluid memory, fluid intelligence, whatever you would like to say, you know. So it shows actually that those who have a lower volume of hippocampus have also reduced ability for the fluid intelligence. And besides everything, in elderly, the diurnal variations are definitely flattened in comparison to younger people. And we also know from many other studies that DHEA is also reduced in men and women, and DHEAS, while the cortisol is increasing through the age, while aging. And the molar ratio is also increased with aging. So the response of DHEA and androstenedione to ACTH after suppression with dexamethasone, you're going to see that in elderly there is a lower response of androstenedione and DHEA. So if I have to summarize what is going on during the aging, so we have increased ACTH and basal cortisol secretion. We have decreased glucocorticoid feedback at the level of paraventricular nucleus, hypothalamus, hippocampus, and prefrontal cortex. Flattening of diurnal pattern of cortisol release, peripheral conversion of cortisone to cortisol is also increased, and decline in pregnenolone and DHEA secretion is also characteristic of aging. Now, I'm going just to show you what is going on with adrenal failure, may I say so. So there is a main difference between primary, secondary, and tertiary in the level of ACTH and in the preservation of adrenal cortex. So in secondary and tertiary form of hypoadrenalism, there is adrenal gland is preserved by, we can see actually after certain time or prolonged time, you're going to see atrophy of adrenal gland. And that has to be taken into account while testing those patients, you know. While in primary hypocorticism, adrenal gland is, or cortex is destroyed. So we have high ACTH level. So I took actually this table just from Williams' textbook of medicine, just to show something. Actually, you're going to see that primary adrenal insufficiency is the most frequently due to autoimmune diseases, isolated or as a part of polyendocrine autoimmune disease type 1 or type 2. So infections also can induce hypocorticism and metastatic tumors to the adrenal glands, sometimes infiltrations with metabolic diseases such as chemochromatosis or immunoproliferative diseases like amyloidosis, for example. And you can see also adrenal hemorrhage that happens a little bit more often among patients who are treated with anticoagulants, and we have to think about that. And from time to time, you can see adrenal hypoplasia due to mutations in DAX1 or CF1. And there might be also ACTH-resistant syndromes due to mutations in melanocortin-2 receptor. So at last, after surgical removal in treatment of Cushing's or metastatic disease, you're going to see also adrenal failure. And secondary adrenal failure you can see actually mostly among patients with pituitary tumors. That's the number one. We are talking especially with clinically non-functioning pituitary tumors and especially after surgery. So after the first surgery, especially after the second surgery, almost all of them are going to become pan-hypopit. So from time to time you can see pituitary tumor apoplexy, which is also associated with hypopituitarism, and you can see postpartal apoplexy as seen in Sheehan syndromes. And from time to time you may see granulomatous diseases. However, these diseases are affects more frequently hypothalamus than pituitary. So rarely you can see isolated ACTH deficiency. In the clinical presentation for both primary and secondary, you're going to see similar symptoms regarding fatigue, hypotension, nausea, vomiting, abdominal pain, and diarrhea. And it is also important that from time to time you can see hypercalcemia due to imbalance of glomerular filtration rate. So it could be from time to time important. However, in primary hypocorticism, you can see hyperpigmentation, dehydration and salt craving, and hyperkalemia. So you can also see vitiligo. And after that, talking about secondary hypocorticism, you have to think about very specific deficiency of pituitary hormones and local compressive effects of tumors. But this is very interesting, you know. In first description of Addison disease, Addison also mentioned heart failure, so we forget it. That means possibly that we meet those patients early enough to correct deficiency, and actually we don't see heart failure. However, if you do knockout, specific knockout in cardiomyocytes for glucocorticoid receptor, you're going to see actually left ventricular dilatation, hypertrophy of the left ventricle, and heart failure. This is not dilated cardiomyopathy, since it has also hypertrophy. So I just wanted to mention that nowadays we are aware of deficiency of glucocorticoids, you know, within the heart, or glucocorticoid effects within the heart. And Addison was completely aware of it. So in testing of those patients, we usually perform standard dose of synthetic ACTH. We collect cortisol at right time, and peak serum cortisol should be above 500s. Somebody say above 600s, but anyway, it's about that. And we usually take a ACTH basal sample. High ACTH suggest, actually confirm the cortical lesion or cortical insufficiency. Low dose was concerned actually as a more physiological stimulation. However, there is a huge variability in results regarding whether we apply, for example, this low dose through infusion, or whether we applied it as a boost. So there is a huge difference in results, and even during the dissolving the preparation, you know, and preparing the dose of the synthetic ACTH, fluctuations of 5% in the amount given to the patient actually induce huge differences in the concentration of the substance within the blood and huge differences in response. So I don't think, you know, still that a low dose of ACTH should be the right choice for the treatment, for the testing of patients. And ITT is possibly the most physiological approach to test hypothalamic-pituitary adrenal axis, but it needs to be done in hospital surrounding, and this is rarely done, except when we test actually people with pituitary tumors and hypopituitarisms. And CRF test is used, you know, to differ between secondary and tertiary hypopituitarism, if it is necessary. So I just want to remind you one thing I said, actually, that the second operation among patients with clinically non-functioning pituitary tumors inevitably leads to pan-hypopituitarism. And the ACTH is the highest among patients with primary hypocorticism, while in those with secondary or tertiary, the lowest is among those who were treated with pharmacological doses for the other reason, for the treatment of other diseases. And a very few moments, I would like to mention, you know, that steroidogenesis is regulated by the ACTH. And the initial step is that by STAR enzyme, STAR enzyme enables transport of cholesterol into mitochondria for the synthesis of all, let's say, hormones. So this first step is the only rate-limited step. All other actually hormones or steroids and the amount of other steroids depends only on the activity of each enzyme involved in its synthesis. So this is important to think when we talk about congenital adrenal hyperplasia. So the lack of STAR is associated with the lack of mineralocorticoid function, glucocorticoid function, as well as androgen function. So due to elevated ACTH, you still have stimulated LDL receptor, which put the lipids, into the cells, of organs involved in steroidogenesis. That means, first of all, within adrenals, then in ovaries and testes as well. So the lack, for example, of 21-hydroxylase is associated with decreased synthesis of mineralocorticoids and glucocorticoids, with accumulation of pregnenolone, and due to that lack, actually, in spite that we have a lot of precursor molecules, we may have also, depending on degree of enzyme deficiency or reduced enzyme activity, we may have overt or subclinical, let's say, mineralocorticoid deficiency, et cetera, et cetera. I'm not going to evaluate this anymore. So at last, this is the normal daily curve of cortisol of healthy persons. And definitely, this is substituted person or persons with hydrocortisone. So usual dose range between 50 and 25 milligrams. And in those with overt lack of mineralocorticoids, we usually add, not usually, but we have to add fludrocortisone 0.1 milligram. It is also important to notice actually that there are actually new substances which have, may I say, better profile during the day of cortisol. And actually you can see what is happening after administration of Plenadren or Chronocort. We don't have these substances at our market, but it is more convenient. I mean, less oscillations we see after administering these new substances. And I would like just to mention one thing regarding congenital adrenal hyperplasia. Actually, we do not substitute only glucocorticoids. Our aim is also to reduce the effect of androgens and to reduce secretion of ACTH. So there are some new substances, which block actually hydroxylase 70A, and this is called abiraterone, and this is involved in synthesis of androgens. And there is another new substance which actually blocks the secretion of CRF and blocks the secretion of ACTH. These therapies are not yet available, but it could be of help. Thank you very much.